Sir, as far as the indications for cardiac MR is concerned, what is your opinion about the place of cardiac MR in ischemic heart diseases?
In ischemic heart disease, there are two important populations which profit very much from cardiac MR. First, the group with stable chest pain, stable angina, especially those which have a intermediate to high pretest likelihood, which currently go to invasive angiography very frequently. And again, very frequently we found that the coronaries are normal in those patients.
Right.
We should base revascularization on the presence of ischemia. And magnetic resonance imaging is a very good technique to assess whether there is ischemia, how much ischemia there is, whether it's prognostically significant, and by thus guide the management of those patients either towards revascularization or towards optimal medical therapy. So this is a very strong indication for a group with stable angina. The second group with ischemic heart disease, or those which are believed to have ischemic heart disease, are those which come to the hospital with acute coronary syndromes. They may have positive troponin, they may have ECG changes, they go to invasive angiography, and then the coronaries are normal.
Right.
So the next question obviously is what kind of problem do these patients have? And with MR, what we can see after the invasive angiography is that a lot of them actually have myocarditis. So they have an inflammation of the myocardium, which we can detect very nicely with MR. So both groups, before invasive angiography or after invasive angiography, are strong indications for doing a cardiac MR test.
Right, sir. And sir, for left ventricular hypertrophy, there are sometimes diagnostic dilemma. So, according to you, what cardiac MR can play a role for left ventricular hypertrophy?
In left ventricular hypertrophy, most patients come to us because they had either ECG changes or an echocardiography which showed left ventricular hypertrophy. And in many patients, this is not explained. It can't be explained by hypertension, or it's more than you would expect, and you don't know what's the underlying reason for the increased wall thickness. With MR, we can very nicely differentiate between infiltrative disease, such as amyloid, or having hypertrophic cardiomyopathy, and see whether it's purely a valvular problem or whether there's an additional myocardial or infiltrative problem. So I think it's worthwhile in patients with unexplained left ventricular hypertrophy to assess whether there is a different underlying etiology than you thought.
Right.
Similarly, it may be helpful in those people who actually train and have a left ventricular hypertrophy due to training, and you're not quite sure if it's still physiologic or if there's a pathologic underlying cause. And rather than sending them to detraining and wait for a couple of months to see if the wall thickness goes down, doing an MRI is a very good way to assess whether the hypertrophy is still in the physiologic range, whether there are additional areas of necrosis which would bring us towards hypertrophic cardiomyopathy, or whether this is most likely just training and as such can be seen as physiological and people can continue to do their sports.
Okay, right, sir. And for sir, patients with presenting with a heart failure, can cardiac MR can play a significant role?
I think it's in both groups. It's patients with heart failure, but also patients with shortness of breath where the ejection fraction is still normal or we don't find anything by echo. The great thing with the echo is we can easily see ejection fraction, volumes, bedside, and it's fast. But on the other hand, we again don't see the underlying etiology of disease because we can't look into the myocardium itself. With magnetic resonance imaging, we have the ability to look into the myocardium by using late enhancement, but that mark irreversible damage and see whether the reduction of ejection fraction or the increase of volumes is due to ischemia, due to DCM, due to myocarditis, whether there are other more rare causes. Similarly, if the ejection fraction is still normal, we can see are the diffuse changes of the myocardium. For example, patients with HFpEF, do we have an underlying problem such as diffuse fibrosis or inflammation or microvascular disease, which can all explain the symptoms, and that is not found if you don't use cardiac MR.
Right, sir. Sir, most of the time the cardiac MR is a kind of underutilized procedure. So, are there any challenges or reasons behind underutilizing it, and how we can overcome these reasons, and what are the solutions?
I think the main reason why it's not used enough is that people think it's a very complicated procedure, so it takes long, it requires a lot of training, and by that it's also regarded as very costly. Indeed, it's not the cheapest test, but if you standardize and if you shorten your examination time, you're actually able to reduce costs substantially. And I think this is an important part to make it available for a lot of people, to make the exam really standardized, really short. We're trying to work on techniques which allow us to do approximately 10 to 15 minutes per patient. And by that, it becomes actually a very feasible technique which should be offered to as many patients as possible.
Right, sir. So, sir, we would like to know what is your key message to all the practitioners and cardiologists as well as the use of cardiac MR is concerned for these very strong indications, the ischemic heart disease, LVH, and patients with heart failure.
So I think cardiologists and physicians should start thinking about the technique as a technique which helps them to better understand their patients. Because if they trust on what they see with echo and with other techniques, they may miss important parts. And especially when you do not offer cardiac MR yet, I think it's important to think about those patients where you don't really know what they have. So patient with unclear left ventricular hypertrophy, patient with unclear shortness of breath, patient with unclear reduction of ejection fraction, those are really good patients. And then when you move towards invasive angiography anyhow, so you have the patient in hospital, you are going to do an expensive test, think about whether the patient really needs revascularization or whether you first need to prove the presence of ischemia. And then again, MR is a very strong test. So think about it and then try to organize it in your environment to be able to offer it.
Okay. So, thank you so much, sir, for such a wonderful discussion on the role of cardiac MR in various disease conditions. Thank you so much.
Thank you very much.